This video is going to go over Chapter 6, the patient hookup procedures. I have very good demonstrations of all these procedures in lab, so I don't know that you necessarily need this PowerPoint, but we'll walk you through it right quick anyway. The hookup is a very detailed and specific process. This is the key to having a good night. If you do a perfect hookup, or I should say a very good hookup, not perfect, that is going to take a lot of stress out of your night because you're going to have less things you need to worry about during your study. From heads to legs, a technician must have a thorough understanding of how every electrode placement affects the overall recording. If your ground or your reference electrode doesn't have good impedance, or if you have a poor connection, then that can affect all the electrodes on your study. So you want to make sure that you get the best hookup possible. Your electrode placements must be accurate, and impedances must be at 5 kilo ohms or below. EEG sites need to be prepped with skin prep. This is an electrically conductive prep solution prior to application with paste. Another way this will be described in some of your RPSGT exam questions is as adhesive gel or abrasive gel or abrasive lotion. And usually with this, you just take a Q-tip or a cotton-tipped applicator, you take a little of the skin prep, and you rub it on each electrode site. You do need to rub it with a fair amount of pressure on the skin because you're trying to remove any dead skin cells, oil, and debris. The EEG electrodes are placed with the cup or disc electrodes filled with conductive paste and covered with gauze to adhere to the scalp. I like to use a type of gauze called cover roll, which actually has one side that's a little bit sticky, kind of like sticky tape. And I use that with the paste, and that really gets a good connection. You always want to split the hair apart and get as close to the scalp as possible. So you kind of separate the hairs and put it as right directly on the skin. And then the hair does get kind of meshed in with the gauze and paste. Collodion glue may be used, but this requires an air compressor to dry the glue, which would then adhere the gauze to the soaked collodion and onto the scalp. So collodion glue, that's what I trained with, and I really enjoy it. It has a stinky smell of ether. It's very watery, but it's very quick and efficient, and you never have to replace those electrodes because they stick very nicely to the head. The problem with that is it needs to be stored in a secure locker, so we don't have that in our facilities here. Electrode impedance. One term that you'll become familiar with is impedance, and this is a measure of electrical resistance measured in ohms. And we talked a little bit about this last week. Remember, we want to have low resistance so we can more efficiently collect the current and measure the voltage. So we want to keep our ohms low. In polysomnography, we want low impedances of our electrodes. This decreases the resistance and it creates better quality of the data. AASM guidelines state electrode impedance must be below 5,000 ohms, which is the same as 5 kilo ohms. EOG, this stands for electrooculogram. Some sites might abbreviate it, like right eye would be ROC, or some might abbreviate REOG. So just difference on your sleep labs and what they prefer. This is going to record the eye movements. The ROG is your right lead, and it's placed 1 centimeter out from the outer canthus of the eye and 1 centimeter up. The LOG is the left eyelid, and it's placed 1 centimeter out from the outer canthus of the left eye and 1 centimeter down. You always need to prep these sites, so you have to be especially cautious not to get any gel or paste or glue if you're using that in the patient's eyes. I always asked my patient to close their eyes when I did this, just so I didn't cause them to jump and it didn't freak them out at all. You can see in the picture above, this is accurate placement of the electrodes. When I look at different images of patients prepared for sleep studies on the internet, like if I Google sleep study, I am amazed at how many patients are hooked up incorrectly, especially with their eyelids. So make sure you follow the rules on that. The chin EMG, this is abbreviated as EMG or the electromyogram, and it's recording the muscle in the chin. That's what myo stands for. We use 3 leads. 2 are active and reference to each other, and then the third acts as a backup. I don't know why they ever started doing this. I suppose because of beards, the chin electrodes came off easily, but this is standard practice. Notice the placement in the picture. One goes right in the front of the chin, and some people have a really deep cleft. You kind of want to avoid the cleft and get on a flat surface on the chin if you can. And then the other two go about an inch, maybe a little bit more, to the side on the underside of the chin. Sometimes I see people moving those electrodes back further on the jawline. If you do that, you're going to get a lot more muscle activity, which is just unnecessary. I guess this says 2 centimeters from the center, so that's about an inch from each other, I guess. Again, this requires skin prep. Be really diligent with men on their beards and stubble. The airflow sensor, we can use either a thermistor or thermocouple or a pressure transducer, and this is placed directly in front of the nose and the mouth. I explained this one more week 1 on the monitoring equipment. The thermistor and thermocouple, they get their signals from temperature, whereas the pressure transducer is the most accurate representation of flow volume. Really, you should use either a thermistor or thermocouple and a pressure transducer. So 2 sensors to measure airflow. The pressure transducer is for identifying hypopneas because it's so sensitive, and the thermistor is used for identifying apneas because it's less sensitive. The snore mic, not all facilities use a snore mic. It is optional. It records the vibrations in the throat. It can be placed either directly in the center of the patient's throat or off to that side in that little triangle there. To check their correct placement, you ask the patient to cough while feeling for the strongest vibration area, and then that's where you'll place it. This does not need to have its skin prepped. Your electrocardiogram or EKG, this is going to record the heartbeat. You place one lead below the right clavicle, and this is going to be your reference electrode, and the second leads are going to be placed under the left lower ribs, and this will be your exploring electrode. This will ensure that your EKG appears upright, and again, this requires skin prep as well. Got to tell you, this is find some ticklish spots pretty easily, so you might want to warn them before you do it that this might tickle. Sometimes I'll even hand it to the patient and let them do it to themselves because you tend to be less ticklish when you do it yourself. So I point out where to do it and have them do it. Leg EMGs. This is going to record movements from the anterior tibialis muscle. Generally, it's listed on the montage as either the RAT and the LAT, which is abbreviated for the right anterior tibialis and the left anterior tibialis. 2 electrodes are placed on each leg, and they need to be about 2 centimeters apart. You verify placement on the anterior tibialis muscle by asking the patient to point and flex their feet, and then you feel for the nice pad of muscle. You should see that muscle pop up from their shin bone. This will help avoid placing the electrodes too far into the calf muscle and too close to the shin. This does require skin prep, and the picture here, they're placed okay as far as where they're located, but you never put the wires going downward from where you place those. The wires should actually be twisted so they're running up along the outside of the knee, and then I string those electrodes up through the patient's pajamas and out through the top of their pajamas. This way they don't get tangled up in them. I also put a little loop in it and tape it to their leg. That way I don't have to fix those in the middle of the night near as often. Respiratory belts record the rise and fall of the chest and abdomen, or the respiratory effort. The thoracic belt should go right under the armpits, and the abdominal belt goes below the ribs. You want to make sure that you don't have the belts too tight or too loose, because both will interfere with your recordings. The oximeter records the amount of oxygen saturation in the blood. The reading can be inhibited by fingernail polish. It can also be inhibited by poor perfusion, which sometimes happens with patients with lung disease and heart disease, diabetes, and with general older age. It can be placed on any finger. My preference is the ring finger. For alternate placements, the probe can be placed on a toe or an earlobe if you're having a tough time getting a signal on the finger due to poor perfusion or whatever. Lastly, when completing a patient hookup, you'll notice very quickly that all of the wires can become a tangled mess. The wires must have an organized flow, be able to find and access any electrode in need of reapplication, and avoid creating a trip hazard for the patient. I lied, that wasn't the last slide. Here are a few tricks of the trade to help a smooth hookup. Prep before the patient arrives. Review the physician order and lay out all your equipment to help speed up the hookup process. Have your gauze cut and laid out, separated from each other so they're easy to grab. Have your paste ready to go. Have your gel poured out and all your equipment out and ready to access. Create a system and stick to it. An example is to start at the head and work down, or start at the legs and work up. My examples show starting at the head and working down, but it kind of depends on where you work, what they prefer you to do. Once you get all your electrodes and recording equipment on the patient, you are going to want to ponytail the wires. What this means is you're going to bundle the wires together to make them easier to manage. I like to use Coban to wrap around the wires and at different intervals down the wire. That way they don't get sticky over time, but some facilities may tape. CPAP desensitization. This can help the patient feel more comfortable and ultimately toss and turn less. Another thing some people use during their hookup process is antiperspirant or mere rubbing alcohol. Both of those placed a little bit on each electrode site will help reduce sweat artifact. And this is the end of this PowerPoint.